Okay, so today we'll be going through IHD evaluation. Perhaps you can start off with three scenarios, which we'll revisit again at the end. The first scenario is a 30-year-old young patient who's a smoker and comes in with what sounds like not very cardiac sounding chest pain with no associated red flags. The second is a 50-year-old female with background hypertension, hyperlipidemia, was admitted for pneumonia with a rise in troponins. She's slightly overweight and has some decreased effort tolerance in the recent years. However, specifically no chest pains. And the fourth is a 40-year-old patient with no past medical history. However, the polyclinic did an ECG on routine health screening and noted some isolated T-wave inversions in V3 to V4 on ECG. So maybe before we look at these cases, then we'll just go through and then at the end we'll revisit them again. Okay. Okay, so Dr. Kwa, how do we go about risk stratifying patients before we decide what tools to evaluate them for in terms of IHD?
Okay. So I think probably the most well-known one that I know of is I think there's a slide after this one.
Yep.
The heart score. So I think this one is, we use it at the Untitled emergency department. So you use this to kind of decide if a patient can be discharged or whether patient needs to stay. So basically taking into account the history, ECG findings, age of the patient, risk factors, and doing the troponin.
Okay.
Right. Sorry. So I think for myself, if a patient is trop negative, I usually don't feel there's a need to work out a patient inpatient, as in there's usually no need for inpatient evaluation. It's okay to send the patient home and to see the patient in clinic for further assessment. Or of course, unless there's ECG changes and troponin, sorry. Yeah. So if a patient is just chest pain, then even if he has risk factors, he's a bit elderly, you can always refer him back to the cardiology clinic. If you are concerned, you can always put the patient on aspirin first. Because even at worst, what he can have is stable ischemic heart disease.
Yep.
Put him on aspirin and then send him to the clinic, and we can always reevaluate from there. Yeah.
Okay.
So Dr. Kwa, maybe you can help us educate us with regards to the different modalities that we use for evaluation of IHD.
Yeah, so the two main aims of evaluation is first, you want to know whether ischemic heart disease is causing this patient's symptoms. So, I mean, a patient has poking chest pain, and obviously is right, or a patient has reflux symptoms, you know that IHD is unlikely the cause of that, right? So you want to establish what is the cause of the patient's symptoms, and two is to prognosticate the patient's cardiovascular risk, whether this patient is likely to have left main disease versus, for example, PDA disease. So these are the two aims of evaluation. I think it's important to remember about pretest probability. So this is from the ACC guidelines. So if your pretest probability is less than 5%, then usually further testing is not warranted. So if you look at this chart which they put against the age, you will notice that in younger patients, if they have atypical pain, actually the pretest probability is already very low. Yeah. So it's not usually recommended to send this people for tests, because you're going to come back with a false positive. You may end up creating anxiety for the patient, and sending them for more tests may indicate more additional exposure to radiation, so on and so forth.
Okay. So
I think the tests can be classified into anatomical or physiological stress tests. So anatomical, as it suggests, is really to see if the patient has any coronary artery disease. So the most obvious one, I mean the most commonly used one is CTCA. So basically a CT scan which is used to scan, we give contrast, it flows into the patient's arteries, you scan the patient's arteries, and then you look to see whether there's any plaque in the patient's arteries. And then of course you have a coronary angiogram, which is the gold standard to look to see if the patient has any coronary artery stenosis. So these are your anatomical tests. And then for your physiological slash stress test, they are divided. So it's divided into the modality, how you're going to look for ischemia, and the stress component. So I think the first one, the most basic, is a treadmill ECG. So obviously you're using ECG to look for ischemia. And if you look at the ischemic cascade, it's one of the last things that will appear when you have an ischemic response. So ECG to assess the ischemic response, and you stress the patient by doing a treadmill. And then secondly, you can have stress echo. So the modality to look at ischemia is the echo, and then you stress the patient by either doing a treadmill, bicycle, or you give glutamine to increase the patient's heart rate. The third one would be a nuclear, or we usually call it MIVI scan, but nowadays we try to avoid using MIVI because it's an old term now, or NPI scan. So the modality is the nuclear scan, where we inject the radioisotope, which goes into your heart muscle, myocardium, and we scan the heart muscle. And then the way we stress the patients, either by using a treadmill, or dipyridamole, or the glutamine. Stress MRI, I don't think is. I'm not quite sure about NUH, because when I was there, they didn't used to do it. I'm not quite sure whether they have started doing it. In UK, it's done quite commonly, but basically use MRI to assess, again, the ischemic response, and use adenosine to stress the patient. Then the last physiological test is it's actually with your coronary angiogram. So basically, doing coronary angiograms, a lot of times we put a pressure wire down, we do physiological assessments. So now there's quite a few that we do. In the past, it used to be FFR, which you have to give medications to kind of cause hyperemia to assess for ischemia. But now we have a lot of up and coming what we call resting flow indices like IFR, RFR, which you can use to assess for ischemia as well. Then CFR is kind of like just to assess for microvascular dysfunction.
Okay, thanks for the overview of the modalities that we have. So I think the next few slides will go through how we go about deciding between these different modalities. I think your next slide probably gives us the broad principles. Yeah. So how do you approach in terms of principles?
So I kind of put it in this way, because I think it really depends on the specialist as well. So a lot of us have our own preference. Yeah. I mean, if you're someone who does nuclear, obviously you'll be more slanted towards nuclear. If you're a guy who does cath, a lot of times we like to offer cath. So it depends on the individual. Yeah, but the broad principle is, so firstly, I think treadmill is falling out of favor. And the reason why I say that is actually in the ESC latest guideline about for ischemic heart disease, the chronic coronary syndrome guidelines, they actually don't advise using treadmill to assess for IHD anymore.
Okay.
So that's one thing. So more of us are not ordering treadmills nowadays. Also, it's important to note that if your patient has any pre-existing ECG abnormalities, then treadmill is usually not so useful. There are a few that are contraindications, like if you have WPW, if LVH, and if LVDD. But what I mean is, even if you have like simple T inversions, if you have a right bundle branch block, then a lot of times you'll come back with like an equivocal result, because they often have a lot of STT changes, and sometimes depending on how gung-ho the cardiologist reporting it, a lot of times they will just put equivocal treadmill ECG. So it's not very useful if your patient has ECG problems.
Okay.
The second broad principle is, if you can run, then we always get the patient to run. So for example, treadmill nuclear versus a dead nuclear, the patient has run, we always advise the patient to run, because it just gives us more information about the fitness of the patient as well. That gives him a better prognosis. For example, if you can run to stage 4, stage 5, if you can achieve 10 meds. So the broad principle is, if the patient can run, he should run. The third principle I would say is, if you know that your patient already has some stenosis before, for example, 3 years ago he had a coronary angiogram for chest pain, and it shows mid-LAD 50%, and then at that time they did FFR is negative, right? So he's been discharged. Now he comes back again, he has chest pain. Then it's more useful to do a stress imaging test as compared to CTCA, because what you're going to get with CTCA, you're going to get CTCA shows me LD 60, 50, 60%. You're going to be stuck. So if you know that there is a stenosis, then do a stress imaging to assess for physiological response of that stenosis to see whether that stenosis is significant or not.
Yeah.
The fourth principle is CTCA is a good test, but a lot of times in elderly patients, they get a lot of calcium. So that is a part of, it's kind of like part of the aging process. So you have to be wary of that and try and don't avoid ordering CTCA for older patients. But for younger patients, it will be
older.
Sorry?
Is there an age cutoff for older or younger? Rough.
Yeah, I put that in the later slide, but I think for myself, I think past age of 65 to 70, I'll be very cautious.
Okay.
I used to order it only if less than 60. But I think the CT machines have been getting better. So in the past, if you order for someone 60, you always come back with stenosis here, stenosis there. But recently, I find that the reports are better. And I think it has also got to do with the CT machines being better. So probably 60 plus is still okay.
Yep.
Yeah. And I think CTCA is a very, very useful test for young patients because it has a very high negative predictive value. So a normal CTCA for me in the clinic is one of the best things you can tell a patient because you can tell them your arteries are perfect. But it is also an expensive test. So I think it's probably the most important expensive test amongst all the imaging.
Okay.
The fifth principle is that waiting for stress echo appointment is going to take a very long time. Because if you have done cardiology, you realize that a stress echo is done by echo tech, and then she just sits there and scans the patient for like almost an hour. So you probably can only do like 3 stress echoes in the morning, 3 stress echoes in the afternoon. Whereas for nuclear, it's like they pop in, pop out, pop in, pop out. It's much faster. So stress echo, if you order it, I think the waiting time in NUH is about 4 to 5 months or something. It can be a very long time.
Yeah.
So I think the overall summary is for most of us, nuclear and CTCA will be the best modalities to go for. And depending on your preference and like I say age and various other factors, it might push you towards one or the other.
Okay.
Yeah, so I think this one I just put there to just show the sensitivity and specificity. If I can summarize, I think treadmill ECG, the accuracy is about 70. I usually tell patients accuracy is about 70 to 80%. For your other stress modalities, it's about 80 to 90%.
Okay.
And then for CTCA, I would tell them that it's normal. I would say it's almost 100 just to make them feel happy. But it's about 97% sensitivity. Yeah.
Okay. Yeah, I think the next few slides you talk about each different modality, some of the things, the practical stuff to look out for. So maybe first.
Yeah, so I guess when we decide there are certain things we may do or not do a certain test. So these factors may play a part as well. So if you have an asthmatic patient, you shouldn't give dipyridamole. But you can do dobutamine.
Okay.
That's a typo.
Yeah, sure.
So asthma also depends on how bad. So obviously a lot of patients have like childhood asthma, that's fine. But if a patient has active asthma, usually inhalers, that's the one that we are concerned about. So second point is if patient has taken coffee or tea on that morning, then they can't be given dipyridamole. They can still go for the rest scan because if you, as you might be aware of, nuclear scans, we do 2 parts. You do the stress and the rest. So they can still go for the rest scan, but they can't do the dip on the same day. So even if the patient is admitted to you, they took coffee and tea that day, you can still ask the lab to do the rest scan first if there's availability of slots. The third point is for left bundle branch block, they shouldn't run. So basically what happens is LVBBs, you have this abnormal septal movement. So it accentuates when you run, it moves even more because your heart is pumping very fast. So even with dip MIB, you might get what we call like a septal dropout because they can't see the septum very well. But I think if you make them run, that artifact is much, much worse. So if you have LBBB, even if the patient can run, you shouldn't run the patient. You should do a deep BB instead for the patient. Other things to note is if you have patients wards who have taken their beta blockers or calcium channel blockers, meaning diltiazem or verapamil, so not nifedipine or amlodipine, so those that lower your heart rate, or ivermectin, then you shouldn't run them now, because if not, they'll be running until stage 7 and they'll never reach their target heart rate.
Okay.
So theophylline use is another thing to ask, and this kind of has it's kind of related to me, because when I was a registrar, I kind of missed this bit about theophylline use. I mean, it was something that we never used to ask. And we also know that theophylline is not something that's given quite regularly nowadays. But there was a patient who was on theophylline, and then after we give dicloridomide, they have side effects. We give aminophylline, right? Aminophylline is the same class of drug as theophylline, so you can accentuate the toxicity of theophylline. So now I think after my M&M case, it has become a routine question to ask about theophylline use. So that's something that we should take note of.
Okay. So I have two questions. So the first is about because you mentioned if you have beta blockers, calcium channel blockers, or that you can't run on the same day, but you can still give the dipyridamole.
You can still do it, but actually ideally we still try not to do it, because what happens is when you assess someone with IHD, right, these agents can also blunt their ischemic response, so you might get like a false negative. Yeah,
yeah.
But it's not something that most people follow. So a lot of, when you're in the wards, actually people will still order it, but if you do read the literature, it's actually not advisable to put them on it now.
Okay. And the second test is about the rest and the stress. Do we normally do it on the same day, 2 days apart? And is the stress always done, or if the rest is normal, then there's no need to stress? How do we get part there?
Such a big topic.
Oh, okay.
Yeah. Okay. So obviously the stress component is more important, right? Because if you have no defects on your stress MPI, then you don't have ischemia. Right? A lot of times we do the rest to kind of see. So if you have a defect on your stress and you don't have a defect on your rest, then you have ischemia. Right? If you have a defect on your stress and you also have a defect on your rest, then that's infarcted, right?
Yep.
And obviously, if you have a normal stress, then there's nothing to compare to. So if you have a normal stress, then you don't need to do a rest scan.
Oh, okay.
Sometimes the techs will still do it because they don't have a doctor to ask. But in NUH, a lot of times, the ED2 patients, they will just ask the radiologist to comment, is a stress test normal? If it's normal, then we don't have to do the rest.
Oh,
yeah,
so
that's the first thing.
The stress before we do the rest. Is that correct?
Yeah, usually you do the stress before the rest.
Okay, got it.
Again, there's another protocol that they do, which I think NUH does as well, is a rest protocol, because they are looking for infarction. So basically, if a rest scan is normal, then they are quite happy to discharge the patient because he doesn't have MI, but he still needs to come back for the stress test another day.
Okay.
So they have this rest protocol thing in NUH.
Sure.
Yeah.
Okay. Can. And about stress echoes?
Yeah. So stress echo. Yeah. So obviously, if you have no legs, you can't run or you can't cycle. The other thing to know about echo is it really depends on the patient. You need to get very clear images to be able to interpret regional wall motion abnormalities. So obviously, a lot of times it's hard to tell until the patient is there for the appointment, when the technician starts to do the first baseline echo. But if you're ordering the test and you suspect that this is going to be difficult to do an echo, then it's probably not advisable to order a stress echo upfront. So if a patient is very fat or has very thick chest wall or has a very big breast, for example, then try not to order the stress echo and put the patient through the hassle. Patients who are too skinny, like the COPD ones, they usually don't have very good windows as well. So usually not a good idea to order stress echo for them. And I think the other thing just to note is for patients with atrial fibrillation, just try to avoid giving dopamine because they kind of go into get this tachyarrhythmia, which can be quite difficult to control after.
Okay.
Yeah. So for CTCA, yeah. So the age cutoff, I put about 65. But again, different people have different preference. So I know some of my colleagues, they are okay with ordering for 70 plus, but I don't really like it because I feel like for me, CTCA, if you get a result, for example, if you have a distal LED 60%, you know that it's not prognostically important, but you're kind of stuck because you don't know what to do. So I usually like to do a CTCA for people that I think is going to get a negative result. So that's my own preference. And I think the main thing to know for CTCA is always try to get the heart rate low. It's like taking a selfie, right? If you keep moving around, when you take a selfie, the picture is going to be very blur. So you need to like lower it with beta blocker ivermectin now. Yeah. So usually target less than 70. Yeah. So I will order it as either the night, the morning itself, or the night before and the morning itself. Just give a low dose.
Okay, got it. Thanks. I think you've answered this question already. Shaban can go to the next question.
Oh, sorry, I forgot about. So CTCA, the renal impairment patients obviously shouldn't do CTCA also.
Okay, got it.
So I mean, a lot of patients come in with MPI like we done like in November. They come in with chest pain, say in like January or February. Then like how do we interpret the validity of these scans, or do we repeat the scans each and every time a patient comes in with a chest pain?
Yeah, so I tried to do a bit of studying for this, but I can't really find anything. I think for CTCA, the validity is actually it's at least 2 to 3 years. I know this was what one of the CT guys in the big names in the UK told me, but so about 2 to 3 years. I think for the other tests, I would say in general, maybe about a year. It's quite safe to say that it's still valid. But again, you have to think about the overall clinical context. So for example, if a patient keeps coming in for chest pain, and if he has a normal stress test, so you must remember that the accuracy of these tests are only about 80 to 90%. So it's not really about repeating the same test again. If the patient comes in again for repeated chest pain, then it's useful to change modality or even offer coronary angiogram just for formal evaluation.
Okay, got it. So the last question would be, what's the role for calcium scoring, or is there any role for hsCRP in the context of cardiac evaluation?
Yeah, so I think calcium scoring and high sensitivity CRP is not so much for ischemic heart disease evaluation. It's more indicates your cardiovascular risk.
Okay.
I mean, if you think about it, it's kind of like, I think most of us tend not to do it in the public setting, in the public institutions. It's something that people kind of do for health screening, like, the health screening packages, you take off what you want to do. It tells you about your overall cardiovascular risk.
Okay.
But I mean, it's the same. It's like, is there anything you can, I'm not sure how as a patient I would take it. Like if you know that you had siblings who died of MI and you don't have any problems now, you know that you're going to be at higher risk, then that's the same for calcium scoring hsCRP. It kind of just tells you that you have a higher risk. Probably the only indication is kind of helps you decide if a patient needs to be on statins. So that's in the guidelines. If you have a patient who is kind of borderline on the indication of whether he requires a statin for his LDL, then if you do a calcium scoring or hsCRP, it might kind of push you towards starting this patient on statins. Because you remember that statins is probably the only thing that's really useful for preventing coronary events in patients who still don't have an event yet.
Okay. So you won't really use this as something to decide on further IHD evaluation. Once again, you go back to the history, symptoms, and stuff like that. This is probably not something that would prompt you to do IHD evaluation.
Yeah, calcium scoring, some people do use calcium scoring for IHD evaluation because you have a negative 0 calcium score. then it's unlikely that you have any coronary plaque. But you have to remember that not all plaques have calcium in them. So I have seen patients with 0 calcium score but have a soft plaque.
Okay.
Proximal LAD 90% soft plaque, and you have a calcium score of 0. So I don't personally use it.
Okay.
Yeah, but some people do.
Got it. Okay, so once again, we go back to the 3 cases. I know they are not very well defined, but perhaps you could just roughly take us through for each of the types of patients, what might be a sound approach in terms of evaluating them, or whether to evaluate them in the first place or not. So maybe you can start with the first 30-year-old guy with the very atypical sounding chest pain, but he has some cardiovascular risk factors because he's a smoker. What would you do for such a patient?
Right. So this is just my view, because
I understand.
as you know, in medicine, everyone kind of is the same, like whether you start antibiotics for chest infection and things like that. I tend not to over-investigate. So for the first scenario, for me, he's a 30-year-old guy. He has atypical chest pain. Based on that risk score that we looked at just now, he is actually going to have a low pretest probability. So my preference is not to do any tests for this patient.
Okay.
If I have to do a test, then I may do a treadmill, but you remember that treadmill kind of, you might end up having false positive, you might end up having CTCA and things like that. So usually for myself, my preference is to reassure the patient. You have to remember that ischemic heart disease is very different from acute coronary syndrome. So ischemic heart disease / patients with angina, their pathophysiology is a chronic plaque buildup over time. So in a young patient, it's very unlikely they have buildup of plaques to 70-80% that will cause them to have angina. But if he comes in with acute chest pain that is typical, it is possible he can have a plaque rupture, because he can have a 20% plaque and then it just ruptures. But it's very unlikely that he's going to have angina ischemic heart / ischemic heart disease. So I will probably not do any tests for him.
Okay, can. So the second patient is the 50-year-old female with hypertension hyperlipidemia. She's the one who seemed to have some myocardial injury following a pneumonia. She is slightly obese as well and has some decreased effort tolerance. So what might be a suitable evaluation modality for her?
Yeah, so I think for her, so one of the things about females is Prof. Tan likes to say premenopausal women, they have very, very low risk of getting coronary artery disease.
Okay.
Right? So 50, kind of like around the menopausal age, not quite sure. I would probably do a test for her. So the first question is, am I going to evaluate her? So I'll probably will do a test, because I guess her troponin is a bit high, right? And she does have some cardiovascular risk profile factors, sorry. And the second thing, actually more important, is because she does have symptoms as well. She has decreased in effort tolerance. So I would do a test for her. And I think in this case, I would do a CTCA for her. I think this is a very good patient to do a CTCA on. It's very high likelihood that she's going to have a normal CTCA, and I can be the bringer of good news in that sense. Yeah.
And so the last patient is probably something that maybe our FEMAT colleagues see a bit more. So it's a patient with cardiovascular risk factors. Oh, sorry, I changed it. So it was actually, if I go back to I changed the thing a bit. So if we went back to our first slide for the last patient, it's a 40-year-old female with no past medical history, but ECG has some changes, some T-wave inversions in V3 to V4. Yeah, so I think it's more of an isolated ECG abnormal finding in the absence of any clinically worrying features. What would you do in this instance?
Yeah, so if you go back to the broad principle, first, when you evaluate, is to assess for cause of symptoms and to prognosticate. So she has no symptoms. So that in itself, I don't think there's a need to investigate. Two, bear in mind that she's 40-year-old, she has low pretest probability. The likelihood of her having ischemic heart disease is very low. So I don't think there's a need to assess her cardiovascular to prognosticate her. For the ECG change, I think most of us might just do an echo just to make sure that there's no structural problems. She doesn't have LVH. So those are, or to rule out congenital heart problems, which might be even more common in her age group.
Let's say this last one, right, we changed it a little bit. Let's say it's an older patient, maybe like 60-year-old guy with some cardiovascular risk factors, let's say maybe DM and hypertension, but no symptoms once again, but has some, let's say, maybe T-wave inversions in maybe V3 to V5 kind of thing. Basically, does the cardiovascular risk factors, in the absence of symptoms, shift the way you would evaluate such a patient?
Yeah, so if they have a higher risk profile, then I might be more inclined to investigate.
Okay.
But if they have no symptoms at all, then the reason is because sometimes revascularization is more to help with symptoms, right? So even if you find an abnormal BV, you might not offer PCI to this patient. But for me, it's kind of, you want to know whether he has ischemic heart disease. You might put him on aspirin, you might give him high-dose statins, and really optimize his cardiovascular risk profile. And that's why I think it's important to do a test to assess for IHD in that patient.
Okay. So finally, before we move on to the take-home points, the last question I have is whether or not, let's say the team that is going to refer to cardio outpatient, right, should be ordering tests before cardio is seen. So I mean, I guess from the take-home that I have is that there are many, many factors to consider, and sometimes it's physician preference in terms of what is the appropriate evaluation modality. But are there instances where it can be quite clear-cut that cardio may prefer the patient to, because sometimes the wait for the appointment can be quite a few months, then the patient goes there, then it's just an appointment to decide what test to be done. So what's your take on this? I think it's more of a practical question.
I think it's useful, but it really depends on the person ordering, right? So
I guess if not, you can consult your cardiology friend to get a sensing. And
I cannot make a statement like that on this page. It'll be encouraging too many referrals.
Sure.
But I mean, I think echo is okay because echo or treadmill is fine because it's not going to be there's not much risk to the patient.
Okay.
But I think if you're going to introduce radiation to the patient, for example, then I'll be a bit more, if you're not quite sure about why you're ordering certain tests, then I would probably not order it. In the ideal situation, of course, a cardiologist should be there screening and then say, this patient do nuclear, do this. And actually in UK, they do it quite a lot. They just receive a phone and say, just do this, just do that. But I think in the Singapore context, probably not advisable.
Okay. So maybe an echo would be something that can be considered where it's probably not invasive and it's a fair baseline test. And then lower pre-ish pretest probability and can run that kind, then maybe a treadmill can be considered also.
Yeah.
Sure. Do you have any take-home points? So we've covered quite a bit, or maybe key things to remember from this session for our residents?
So I think evaluation IHD is quite a big topic, and given more and more trials that have come out, bearing in mind the most recent one, which is the ischemia trial, where it shows that even if you revascularize someone with a large area of ischemic myocardium, it doesn't really reduce their cardiovascular outcomes. I think the evaluation, we have to be a bit more sensible in ordering these tests, because a lot of these patients actually do the test because they think that they are going to live longer if their test is normal. But a lot of times it's not true. A lot of times it's about optimizing your overall risk profile as well. I think that's more important rather than just ordering tests blindly for these patients, especially if they have no symptoms.
Okay, got it. Okay, thank you very much.